I am so pleased to see the people I know are here. I think there's only one person who is probably more excited than me. If you're a Memorial alumnus, you know who that person is, Dr. Rosenblum. He's already waiting for you at the Water Club. So let's get rid of this case. The history is that, clinical history is, this is a 70-year-old female with abdominal pain and jaundice. And CT scan reveals a 1.8 centimeter mass in the common bile duct, causing intra and extra hepatic duct dilatation. Lab liver function abnormality with a pattern of biliary obstruction, high bilirubin and high alkaline phosphatase, and also serum CA 19.9 is also very high. And a low power view showing a tumor is indeed within the bile duct. So given the clinical information and also preliminary pathological assessment, this is probably a tumor originated from this site. So preliminary diagnosis, I think pointing towards a cholangiocarcinoma. If this is what you had thought about, you may be on the right track, but I'm afraid that you're on the wrong train. So cholangiocarcinoma usually are derived from biliary epithelium with a precursor dysplasia. In this case, in the entirely submitted biliary tree, we do not see any dysplasia. Here's another view showing that the tumor is actually subepithelial in origin. And the surface epithelium you can appreciate with a very mild atypia without metaplasia or dysplasia. Another view showing that the tumor is actually growing from the subepithelial region into the lumen, forming a polypoid mass. The pattern, histological pattern, is nested with varying sizes of nodules separated by fibrous or vascular structure. And the dominant pattern is nesting. Higher power view reviewing relatively uniform nuclei with somewhat stippled chromatin, moderate cytoplasma. However, the mitotic activity is very apparent. In a small area of the tumor, which shows some tubular or rosette forming, this is a very important feature. So based on the clinical and histological history, we come up with a differential diagnosis. And if you have thought about the same, you should be very proud, Memorial alumnus. Well-differentiated neuroendocrine tumor or carcinoid tumor. This is based on the morphology, the growth pattern, as well as the chromatin pattern. Because of the neuroendocrine morphology and the high mitotic activity, one should also consider a poorly differentiated neuroendocrine carcinoma. And because the tumor is in the bile duct and also there's a high CA 19.9, cholangiocarcinoma is still in the differential diagnosis. So we were able to confirm the neuroendocrine differentiation by positive immunoreactivity for both chromogranin and synaptophysin. However, the positivity is not really brilliant. You see it's focal, patchy, and sometimes almost negative in some of the cells. Nevertheless, we still consider a well-differentiated neuroendocrine tumor or carcinoid tumor based on constellation of other information. However, one puzzling issue is variety of the tumor, different areas of tumor showing high and low proliferative activity, ranging from 19% to 80%. This is unusual for a well-differentiated neuroendocrine tumor or carcinoid tumor of the bile duct. So we thought about the possibility of a phenomenon we have recently described, which is a well-differentiated neuroendocrine tumor with high-grade transformation. Morphologically, it may be difficult to appreciate the transformation on H&E. For example, here, however, if you do a Ki-67, sometimes it can be very dramatic. This is an example of a very different proliferative rate within the same tumor. So we try to explain this in our case. Perhaps it is indeed a tumor with high-grade transformation, although in our study, the majority of the cases were pancreatic primary. So it's uncommon for GI tract or biliary system. But you have to think about with, I mentioned earlier, a portion of the tumor showing very significant morphology, which is either, as you can call it tubular or rosettes or acinar. With this morphology, you know one person will not let this case go. And we have to go fishing. What we're fishing for is a fish called Acinar. So we requested additional material, and surely enough, there was immunoreactivity for both trypsin and chymotrypsin. So this tumor indeed has acinar differentiation. Both immunoreactivity exceeded more than 30%. So with that new findings, we narrowed down to neuroendocrine and Acinar. The best description would be a mixed Acinar and neuroendocrine carcinoma, or MEC. So regarding this entity, if you are a Memorial alumnus, you should know who described this first. So it's extremely unusual if you consider pure neuroendocrine tumor in the pancreas is only 2%, and Acinar is even less. So the combined phenotypes is much less than 1%. And you must have at least more than 30% of each component. And theoretically, there could be three possibilities in terms of histological pattern. The neuroendocrine and Acinar can be completely separated as a two distinct component, which would be easier for us to recognize on H&E. However, they can be admixed. In this case, probably representing our case, it will be very difficult to recognize it on the morphological basis alone. And finally, the so-called amphicrine phenotype, meaning the same tumor cell expressing both endocrine and Acinar markers. So there are very few reported cases of extrapancreatic primary MEC, including ampulla, jejunum, and the stomach. And these are actually sites of common for pancreatic heterotopia. So the final diagnosis is mixed Acinar and neuroendocrine carcinoma, given the fact that clinically there is no disease elsewhere. We consider this as a primary common bile duct MEC. So luckily, this has been described. The pancreatic heterotopia has been described in the common bile duct. So we believe this tumor is indeed a bile duct primary arising from pancreatic heterotopia. So what we have learned from this case is, number one, when dealing with a neoplasm with neuroendocrine morphology, one has to consider the following. First of all, a differential diagnosis should include a well-differentiated neuroendocrine tumor and a poorly differentiated neuroendocrine carcinoma. The distinction can be tricky and difficult, and one should not use Ki-67 alone as a sole marker to separate the two. And I don't have time to elaborate more into details, but just remember to keep these two in mind and investigate further. And next point is the distinction between neuroendocrine and Acinar phenotype may be extremely difficult on the morphological basis alone. So extensive histochemical workup may be necessary to confirm the diagnosis. And finally, when you're thinking about Acinar, the clues are the following. Neuroendocrine tumor with, you think it's a neuroendocrine tumor with a histological and cytological pattern, with an elevated mitotic rate and or Cas67 index, or the presence of nucleoli even focally, like in our case, or presence of rosettes or Acinar architecture. So with that, I thank you for your attention.